Last night, we had just a magnificent dinner right here in this room. Were all of you here last night for the magnificent dinner? Yeah. Charles Dahlquist did a great job of being a real MC. Didn't you think he did a great job? Like of a real grown-up MC? Absolutely he did. But he put a lot of pressure on me. He recognized all of our illustrious luminary guests, including our next speaker. And he'd been practicing, Charles, to be able to pronounce the name of our next guest. I think he'd done research. He visited India to figure out the correct pronunciation. And he pulled it off flawlessly. So I'm sort of Charles's understudy. And so I've been working on this. Our next guest is Ananda Bandyopadhya. No, it's close. Was it close? Yeah. Yeah, Charles nailed it last night, so how many more ways can we prove I just know Charles Dahlquist, that's for sure. Ananda grew up in Kolkata, India, and completed his medical graduation from Calcutta National Medical College and Hospital with a gold medal and multiple honor certificates in 2005. He received his master's in public health degree in global health from Harvard, the Harvard School of Public Health, and he worked for the WHO polio surveillance team project in India in the years leading up to the successful eradication of polio there. Today, he works for the Bill and Melinda Gates Foundation as a senior program officer focused on disease eradication, with much of his work focused on polio in cooperation with Rotary. Please welcome Ananda Bandyopadhya.
Good morning, everyone. It's quite a privilege and honor to be here. I had been warning Devin not to try pronouncing my last name. He wouldn't listen. He did try, did a reasonably good job. As I said, it was this close, almost like the eradication timelines. But again, it's always been an inspiration whenever I have come to Rotary District conferences. Just the vibes in here, the energy and the passion that you all bring in is really infectious. So today I'm going to talk about a disease I love to hate, polio. And before I begin, I would just like to ensure we all understand the challenges and the scale of the battle that we have in front of us. And one of the reasons is the fact that we are set out for disease eradication. It's not only control, it's eradication what we target in this campaign. And the only human disease that we have ever eradicated is, as you all know, smallpox. So again, just as a brief recap of what eradication really means, it's the permanent reduction of a particular disease and its incidence to zero, and that reduction of disease incidence or infection to zero has to be global or worldwide. So that is really the challenge with polio, to be the second human disease to be eradicated. As long as one country, one district, one province, or one village has polio, we are not there when it comes to eradication. So again, keep that in mind. That kind of sets the tone about the level of intense involvement the global agencies need to have to get to zero. And again, zero at the level of the world, at the global level, essentially. And it's a disease that has existed since ancient times. So you can see in this Egyptian stela, the right foot of this particular priest has typical polio-like deformity. So probably it has existed since ages, and we do find descriptions of polio and polio-like paralysis since over the past 200 years or so in the medical literature. So it's an ancient disease that we have been fighting, and please note that it is a deadly disease and highly infectious. We don't get to see polio too often around, of course, thanks to vaccines and vaccinations. But it wasn't the case, even in the last centuries. These are what we used to call death curves, mortality curves from the New York City back in 1916. And you can see the devastation polio used to have, in those times, essentially. So thousands of people would die of polio, and those who would survive would have lifelong paralysis. So it is a deadly disease, and as long as it's there somewhere, it's essentially a plane ride away. Now, what really made the difference are the vaccines. So 1955, we got the Salk injectable inactivated vaccine licensed. Soon after, by early 1960s, we had the Sabin vaccine, the oral polio vaccine, licensed as well. And that really led to dramatic decline, not only in this country, but worldwide, of the polio cases that we see. So these are this is essentially the disappearing act of polio, as I call it. So you can see, the last case in the Americas, the WHO region of Americas, was in 1991. This was the child. And then the last WHO region to be certified polio-free was India, and this child, Ruxana, was the last child affected with polio, a child who lived around 10 kilometers from where I grew up, as a child in Kolkata. So this shows you the spectrum of the battle against this disease from one region to the other. And this slide summarizes the remarkable progress against polio from a time back in 1988 when Rotary spearheaded this campaign, along with taking with the other partners, other global partners, with the WHO resolution to eradicate polio. And then what was formed was called Global Polio Eradication Initiative, GPEI. From that time of 1988, when one would have 1,000 cases of paralytic polio every day in the world, we are now down to, as you can see, 33 last year of paralytic polio cases in only 2 countries. So that has been the remarkable scale of progress. Again, thanks to Rotary, and thanks for for it's essentially having the idea of such a global campaign and then bringing the global partners together. As I said, WHO, CDC, UNICEF, and now Gates Foundation joined in as well. So this gives you a snapshot of the progress that we have made, and essentially millions of volunteers have been involved, including the Rotarians who have delivered the vaccine and have prevented, as you can see, around 18 million paralysis in the world with the vaccination effort. So a massive scale when it comes to a public health program that we have ever seen in the history. Now, the complexity around polio. Polio essentially, from a medical and public health standpoint, is a combination of many diseases. That's part of the complication in eradicating polio. Broadly, it can be of 2 categories: the wild or the naturally occurring polio virus or disease, and the vaccine-associated or vaccine-related polio disease. And each of these categories can have subtypes based on the serotype of polio, WPV, or type 1, type 2, and type 3. So these issues around the immunologic perspective, virologic perspective of polio makes it quite a complex disease to eradicate, because not all the subtypes would react to vaccine or vaccination efforts similarly, and also they don't present in a similar manner. So as you can see in this slide in here, the type 1 polio is by far the most virulent form of polio. If around 200 subjects or 200 people would get infected with type 1 polio, at least one would have paralysis. So it's subclinical, but compared to types 2 and 3, it's less subclinical and more virulent. So for example, type 2 polio would infect around 2,000 people to get one person with paralysis. It's way more subclinical than type 1, and it causes less paralysis compared to type 1. Right now in the world, in those two countries that I just mentioned, which still has polio, it's only wild type 1. So we have made tremendous progress in either eradicating or potentially eliminating the other types of polios. As you can see in here, there was quite a ritual actually to mark the eradication of wild type 2 polio, which was last seen in 1999 in India. So if you are ever asked how many human diseases we have eradicated, you can cite me and say 1.3. 1/3 of polio is already gone, for sure, and certified gone. Wild type 3 is also possibly gone. We last saw a wild type 3 polio back in 2012, and we have never seen a wild type 3 polio in the world again. So essentially the battle to eradicate polio when it comes to wild type disease, it's now focused only on wild type 1. This is quite important from a perspective of what vaccine do we use against this virus and how many times we vaccinate and so forth. Now, there is also a spectrum of polio disease which are linked with the vaccine that we use, the oral polio vaccine, an extremely effective vaccine, an affordable vaccine, and also a vaccine that can be delivered, as you can imagine, very easily from a house-to-house campaign perspective. And many of you have done that, have been to some of the endemic countries and have delivered the oral polio vaccine yourselves. But in rare circumstances, particularly in areas of poor immunization background, the vaccine virus itself can revert to what we call neurovirulence, basically meaning they can cause paralysis themselves, and they can also be transmitted from one person to the other with that revertant strain circulating. Again, very rare, and mostly it doesn't happen that way. And the conundrum is it only happens if the background immunization rate is already poor, allowing this circulation to happen. But it is an evolving area of great concern, and I'll show you some slides that depicts the battle against not only that wild type 1, but the spectrum of the vaccine-derived polio disease. And again, the other part of the puzzle is, although wild type 2 has been eradicated, it is the type 2 component of the vaccine that causes maximum number of vaccine-derived polioviruses. That was linked with a global policy change in 2016, which basically led to withdrawal of the type 2 vaccine virus component from the oral vaccine. And these days you only have what we call the bivalent oral polio vaccine that is used predominantly in the world, and type 2 oral polio vaccine is only saved as a stockpile option. Now with that, let's have a look at the snapshot of the world as we speak right now as to where exactly polio hides. So the red dots are the wild type 1 polio cases, and as you can see, clearly it's only 2 countries, and this is a depiction of the past 6 months, essentially mostly capturing this year of polio epidemiology. And as I said, it's only Pakistan and Afghanistan where we still have wild polio transmission going on. Rest of the world is polio-free, is wild polio-free, which is amazing, particularly given the challenges we have in several other countries in terms of access. Now, the story doesn't end there, and that's why I showed you the last slide. There are vaccine-derived polio transmission going on in parts of Africa primarily, and the green dots depicts where the type 2 vaccine-derived circulation is going on as we speak. And there's also some transmission in parts of Asia, Indonesia to be precise. But these are focal transmission, as I said, primarily driven by existing poor immunization quality and coverage. Pakistan, Afghanistan remains the primary challenge when it comes to the wild polio virus eradication. Now, you may ask, why is this the case? Why we still have polio in certain pockets of the world, while 99.9% of the world is actually polio-free and remains polio-free? I just have two images to depict some of the challenges that are going on in these geographies. So this is an image from Nigeria. Nigeria is also a polio endemic country, although it didn't report wild cases in the past 2 years. We still consider it endemic, just to be, extra caution about what kind of circulation might happen there. This is a photo of the health facility in Borno in Nigeria, destroyed, as you can see, with the local insurgency that's going on in that part of the country. If the primary healthcare facility is in this situation, literally demolished, you can imagine the impact it would have in any healthcare interventions, including the intensity of vaccination that we would like to ensure when it comes to the polio eradication program. And the story is not much different when it comes to Pakistan and Afghanistan. Of course, there is ongoing insurgency, war going on, as you all know, in that geopolitical area of Pakistan and Afghanistan. But the situation around vaccine hesitancy or vaccine resistance has also taken a whole different spectrum in this part of the world. So you must have heard about, words like vaccine resistance, vaccine reluctance, resistance, and so forth. But how many of you have really heard that resistance could mount to an extent where innocent vaccinators are killed, shot down while they're conducting vaccination campaigns? This is one of the families affected in Pakistan while conducting the house-to-house vaccination campaigns. Sakina Bibi, 33-year-old local woman vaccinator, was shot down along with her 11-year-old child. Again, conducting house-to-house vaccination, trying to protect her own community from this disease. So this is the extreme spectrum of the resistance in parts of the world that the program faces that we probably would have never imagined we would have to face. But the program goes on. As we speak, people like Sakina Bibi are again taking up the vaccine career, maybe in the same village, and trying to vaccinate kids and protect the community. But that gives you a glimpse of the challenges that we face in some of these areas. The only other piece of the epidemiology that I would like to bring focus to is this issue of vaccine-derived poliovirus circulation. Linked with that policy switch to withdraw type 2 oral polio vaccine from the trivalent oral polio vaccine that we have, unfortunately, we are still seeing, even 3 years after that withdrawal of the type 2 oral vaccine, we are still seeing extensive circulation of the type 2 vaccine-derived virus, as you can see in here, primarily in Africa. And the problem is the only tool for now that we have to fight this vaccine-derived virus of type 2 is again the oral polio vaccine type 2, which in itself, as I said, in rare circumstances can seed new vaccine-derived virus circulation. So it's a huge conundrum really in terms of options to fight this circulation. And again, as I said and I repeat, had the immunization coverage been optimum, we wouldn't have seen this issue. It's only with poor pockets of immunization that this vaccine-derived viruses pop up. But again, as I said, right now the only tool is the oral polio vaccine type 2, and from a stockpile option that we have of this vaccine, we are releasing this vaccine time to time to fight these outbreaks that are going on. It's quite a complex situation in these parts of the world. Now, the only last thing I would highlight, given the challenges in global epidemiology, the geopolitical situation that we face, we continue to make tremendous progress when it comes to research and development around the eradication program, be it the vaccines that we have, the delivery methods of the existing vaccines, developing new vaccines for polio even at this point in the program, and also improving surveillance for polio, coming up with newer tools of how we collect the sewage samples in these high-risk areas to rule out if the virus is circulating in the environment. So a big range of research and development projects that we support. And a glimpse of it is in this table, which is only focusing on the vaccine development research that we are funding and that we are getting involved very deeply with. And you can see the spectrum is huge, from adjuvantation of the existing vaccine to make it more immunogenic, to make it more affordable, to make it more scalable in terms of production that eventually brings down the cost, to developing newer routes of vaccine administration. So developing microneedle patches, what we call jet injector devices, so that the administration of the injectable vaccine is easier and is more field friendly. And lastly, the one vaccine development project that we are deeply interested in, Bill is very much focused on supporting this project, is to develop what we are calling new OPVs, which are supposed to be genetically more stable than the current OPVs. So that small, rare risk of the vaccine virus reverting into neurovirulence and transmitting from one person to the other is negligible with this more genetically stable new oral polio vaccine. And dramatic progress has been made in developing this vaccine. This is the first polio vaccine development effort in the past 60 years. And it has been very difficult. Over the past 2 to 3 years, we are trying to ensure the clinical trials around these vaccines are accelerated, given what we are seeing in parts of Africa with those cases of vaccine-derived polio that you saw. But we couldn't do these studies out in the open because, you had to ensure that what you are testing is actually safe and is not putting the community at further risk. So we developed what we call a contained village in Belgium. We took containers out of Czech Republic, brought it into a university in Belgium, set up this setting back in 2017, and essentially 30 subjects, 30 adults stayed into this contained village for 28 days or so, and we tested that new oral vaccine in this adult volunteers in 2017. In 2018, we got the results promising, supports further movement into infants and toddlers. And right now, as we speak, clinical trials are ongoing in Panama, another trial in Belgium, no longer in contained setting because the safety was established. And we hope that in the next year or two, in a very short span of time, we might have this vaccine as an additional tool to complete and sustain eradication. Again, the current OPV and the IPV would remain the mainstay, but this could enhance the fight, particularly to bridge the gap around the vaccine-derived poliovirus issues. So that gives you a very quick snapshot of the battle right now, the global geopolitical situation, also the research initiatives that we are supporting. But what does that tell you about the vaccine? What is your idea about the existing oral polio vaccine as you see in this picture right now? So these are oral polio vaccines in sealed vaccine vials. How effective is this? Any idea? Come on, the old one. Good question. Governor Scott asks how many doses. So that links to the trickiness of this question essentially. My point is, and this is one message I would like you all to take home. No matter what kind of vaccine we develop, be it the new oral vaccine or the existing oral vaccine, or no matter how much scientific innovations we do, as long as the vaccine is in the sealed vials, it's 0% effective. What really makes it effective is vaccination, is what you all help us do, and what the vaccinators, those women that you saw in that picture, help us do. Vaccination really saves lives. Vaccine in isolation may or may not. And friends, vaccination in the real world is no less than an Olympic sport. These are people, these are the real heroes of the polio eradication campaign. And as I say, if there is ever a global health Olympics, my polio vaccinators would be the champions. So you can see this guy, jumping in between the mountains with the vaccine carrier with him, maybe trying to get reach to 4 or 5 families on the top of a hill in northeastern India. To this guy, to me, a weightlifting champion in the Global Health Olympics, he's lifting up that vaccine carrier box with hundreds of vaccine vials in there. But look, the situation he is in. He's knee-deep into flooded waters. To this 80-year-old volunteer vaccinator swimming his way through from one village to the other in severe flooded conditions, but keeping the vaccine carrier afloat. These are the heroes. Women vaccinators have really changed the landscape of polio vaccination. They go house to house. They are from the community locally. They can get access to the mothers, and they can ask about the children, find the children, and vaccinate. And lastly, you all, you are the heroes of this campaign. You are the reason of where we are today as a global community. And Bill's quote is most appropriate here. The world would not be where it is without you all, and it won't go where it needs to without you all. I end by saying that. And just to summarize, I think it's a very complex eradication program. I didn't get into all the details, but I just gave you some glimpses of the major challenges. So our focus remains interruption of the transmission, both of the wild virus and the vaccine-derived virus. We need to do it along with innovations that are happening in the vaccine and the surveillance research spectrum. But very importantly, we need to strengthen the advocacy efforts, the partnerships to ensure there is no funding gap. It's a huge program, as you all know, at a global scale. It requires a lot of intense advocacy and funding. We need to maintain the momentum so that those 33 cases last year actually goes to 0 very soon. And again, the scale of progress you have seen from 1,000 cases every day globally to 33 in 2 countries. And I would end by, again, recognizing the efforts of the women vaccinators. Tomorrow is the World Mother's Day, and I don't think there is anything that better defines universal motherhood than the cause of vaccination and the way these vaccinators have really championed the cause of disease control and eradication. And interestingly, much like this photo that I took around 15 years ago, the face of the vaccinator and the name of the vaccinator still remains unknown. But it ensures that the mother of the child has a radiant, bright smile, and hopefully the child who gets vaccinated will thank all of you for your effort to eradicate polio. Thank you.
Thank you very, very much.